morning everyone. Myself I Sinduri, second year PGT of Com JNM. Today's my topic is histopathological examination of granulomatous dermatosis. So a definition of granuloma is organized collection of epithelioid histocytes with a range of multinucleate giant cells and other inflammatory cells. The word organized signifies that the granuloma would be a tight ball-like arrangement of macrophages. So the granuloma is attempt of immune system to eliminate foreign material which can be exogenous, endogenous, infectious or non-infectious. Granulomas are composed of epithelioid histocytes which fuse to form multinucleated giant cells like Langerhans giant cell. So epithelioid cells are derived from macrophages and usually contain slipper-shaped nucleus. So coming to type of giant cells, they are Langerhans, not Langerhans. Langerhans has horseshoe-shaped nucleus, can be seen one side or both the sides. Foreign body cells contain regular nuclei scattered throughout cytoplasm. Teuton giant cells seen in adipocyte diseases where peripheral cytoplasm will be vacuolated. Tumor type of giant cell contain hypochromatic pleomorphic nuclei scattered throughout cytoplasm. Classification of granulomas can be tuberculoid, sarcoidal, necrobiotic or palisading, suppurative, foreign body, xanthogranulomatous and miscellaneous. Sarcoidal granulomas are described as neat, clean and compact granulomas, tightly packed epithelioid histocytes and which contain multinucleate giant cells which can be Langerhans or foreign body type with naked appearance, that is paucity of lymphocytes around the granuloma. So typical sarcoid granuloma contains few times asteroid and Schwann bodies. Asteroid being eosinophilic star-shaped structures inside the giant cell. Schwann body cells are concentric calcified laminated structures within giant cells. So the sarcoidal granuloma can be seen in sarcoidosis, Blom syndrome, foreign body reactions, secondary syphilis, Sézary syndrome, metastatic Crohn's disease, orifacial granulomatosis, sarcoidal type of granuloma annular, herpes zoster scars, systemic lymphomas, breast cancer and the rest. So coming to sarcoidosis, the clinical manifestation of sarcoidosis has been described as protein, which was derived from name of sea god Proteus, because he can change the shape of him according to what he needs. So clinical features are briefly divided as specific and non-specific. Specific being the one which contain granulomatous histology. That includes papules, plaque, lupus perennial, nucleus syndrome, Dairy Rosai sarcoid, that is subcutaneous sarcoid, Lofgren syndrome, Hereford syndrome. And non-specific includes erythema nodosum, erythema multiforme, neutrophilic dermatosis. So here is the slide showing diascopy with apple jelly type nodules which is seen in sarcoid, LMDF and lupus vulgaris. And the rightmost picture showing scar sarcoid and left to right, the left one being periorbital papule seen in sarcoid and middle pic indicating a lupus pernio and the rightmost is also a lupus pernio. So histopathologically, sarcoid granulomas contain non-caseating epithelioid granuloma with sparse or absent surrounding lymphocyte. In right picture, we can see two asteroid bodies. So the histopathology of sarcoidosis have been used historically in Kevin's test, wherein the spleen and lymph node of sarcoid patients are crushed and injected into a patient whom we suspect sarcoidosis, then followed by 4 to 6 weeks we take the biopsy of the injection site to see histopathologically a sarcoidal granuloma. So Bloss syndrome, in which we can also see sarcoid granuloma, is actually autosomal dominant, characterized by early onset granulomatous inflammation caused by NOTQ mutation, clinical trials of which includes granulomatous dermatitis, granulomatous uveitis and arthritis. Coming to foreign body granuloma, it is a response to introduction of exogenous material to the skin or in response to modified endogenous material that immune system considers as a foreign material. So it can be caused by metals like silica, zirconium, which is used as an antiperspirant, aluminium, titanium, and zinc, tattoo dyes like mercuric sulfide, ferric hydrate, cosmetic fillers like collagen, silicone, paraffin, hyaluronic acid, medications such as intralesional corticosteroids, polyvinyl pyridolin, which is seen in povidone, and hydroxyquinone. Ruptured cyst, hairs, and calcium. Histopathology consisting of caseating or non-caseating granulomas surrounding by foreign material. So the polarized light microscopy can be helpful to identify polarized material in case of obvious foreign material. So from the left to right, pictures was taken from DermNet, left one being tattoo granuloma and middle pic showing bovine collagen induced foreign body granuloma, and right one being silicone foreign body granuloma. Here is another picture showing granulomatous reaction to niloid suture material, which is at the center. Coming to tubercular granuloma, they are less circumscribed, more confluent with dense lymphoplasmocytic infiltrate than sarcoidal granuloma. So Langhans giant cell are characteristic giant cells seen in tubercular granulomas. They are seen in a number of conditions starting from tuberculosis, tuberculate to idiopathic facial aseptic granuloma. So the tuberculates can be classified as true, facultative, and non-tuberculate. True tuberculosis is caused by Mycobacterium TB. Facultative can be caused by both Mycobacterium TB and Mycobacterium bovis. So true tuberculates include lichen scrofulosaurum, papillonecrotic tuberculate, facultative being erythema induratum of Besson. Non-tuberculate, which is not caused by any of the mycobacteria, was previously considered as tuberculate, includes LMDF, rosacea-like lichenoid. So the tuberculates contain well-formed epithelial granuloma with scant AFP. Leprosy ranging from tuberculoid, borderline tuberculoid, and borderline, we can see tubercular granuloma. So in the tubercular, TT pole gran zone is absent, in BT pole narrow gran zone is present. So a typical granuloma of leprosy can be defined as superficial or deep, well circumscribed, oval, oblong, or curvilinear infiltrate in a perivascular or periappendageal distribution. Syphilis, secondary and nodule of tertiary syphilis can show tubercular granuloma, where plasma cell will be predominant, and vascular changes in the syphilis include endothelial cell swelling and endarteritis obliterans. In leishmaniasis, along with tubercular granuloma, we can see epidermal changes, and rarely LD bodies indicating mastocytes can be seen. In granulomatous rosacea, along with the tubercular granuloma, we can see perivascular and perifollicular granulomas with dilated dermal blood vessels. Here is the slide showing histology of tubercular leprosy. First arrow, we can see the gran zone is absent, and the second arrow indicating a curvilinear tubercular granuloma. Again, the magnified view of previous slide, where we can see collection of histiocytes and a granuloma. And right slide showing absent gran zone with Langhans type of giant cell. On granulomatous rosacea, in superficial dermis, we can see dilated blood vessels in the first arrow, and second one showing a granuloma, well-defined granuloma. LMDF, we can see in the left pic, classic caseating tubercular granuloma. Coming to necrobiotic or collagenolytic granuloma. Necrobiosis means death of cells or tissues. The center area will contain necrobiosis with surrounding granulomatous inflammation. So in the granuloma annular, which indicates classic necrobiotic granuloma, mucin will be abundant. Whereas rheumatoid arthritis, we can get fibrin predominant in the center of the granuloma. So necrobiotic granuloma can be seen in granuloma annulae, necrobiosis lipoidica, necrobiosis xanthogranuloma, rheumatoid nodules, rheumatic fever nodules, and miscellaneous disease. So HPE of granuloma annular can be divided into two classic findings. One is interstitial and other one is palisading. In interstitial, being the most common, it contains degenerated collagen with minimal mucin. Whereas palisading type contains central necrobiotic collagen with abundant mucin surrounded by palisading histocytes or lymphocytes. So here mucin can be elucidated using Algerian blue or colloidal iron stains. Annular elastotic giant cell granuloma contain elastophagocytosis and asteroid bodies. Verhoeven von Jessen stain can be used to demonstrate absent or destroyed elastic fibers. Rheumatoid nodules, to differentiate between granuloma annulare and rheumatoid nodules, we can do rheumatoid factor assay and anti-cyclic citrulline peptide antibody in the laboratory investigation, and histopath being fibrin will be abundant rather than mucin. Necrobiasis lipoidica, diffuse palisading and interstitial granulomas will be seen in horizontal tire fashion. The lipid content can be demonstrated with adipophilin or oil red O. Necrobiotic xanthogranuloma, cholesterol cleft or found in the areas of necrobiasis. Two-tone giant cell and large Bezier foreign body giant cells can be seen. Palisading neutrophilic and granulomatous dermatoses contain palisading and interstitial granuloma with prominent neutrophils and leukocytoclasia. So classically, palisading granuloma can be seen in granuloma annulare, necrobiasis lipoidica, rheumatoid nodules, and palisading granulomatous neutrophilic dermatitis. So this slide is showing interstitial or infiltrative pattern of granuloma annulare, where we can see that the histocytes are between degenerated dermal collagen with a scanned mucin. Second one showing palisading granuloma of GA, where we can see abundance of mucin in center along with necrobiosis. This is annular elastotic giant cell granuloma, where we can see fragmented elastic fibers in the giant cell indicating elastophagocytosis. Necrobiotic xanthogranuloma, in the center we can see numerous cholesterol cleft under the background of necrobiosis. Xanthogranulomas, they're typically seen in juvenile xanthogranuloma, also in non-Langerhans cell other non-Langerhans cell histiocytosis, reticulohistiocytoma. Suppurative granulomas, they are characterized by center of neutrophilic collections which are surrounded by epithelioid histocytes with or without giant cells. They can be seen in n number of conditions in subcutaneous mycosis, mycobacterial infections, atypical mycobacterial infections, mycetoma, cat-scratch disease, lymphogranuloma venereum, pyoderma gangrenosum, and ruptured cistern follicles. Miscellaneous granuloma, which does not fit under tuberculoid, sarcoidal, or necrobiotic granuloma, or following: Chalazion, Bulker cell Rosenthal syndrome, elastomyelitic granuloma, annular granulomatous lesion and ochronosis, granulomas in immunodeficiency, interstitial granulomatous dermatitis, interstitial granulomatous drug reaction, ID reaction, granulomatous T-cell lymphoma. So the special stains which can be used is reticulin in sarcoidosis and TB, von Kossa for Schaumann bodies to demonstrate calcium deposition, phosphotungstenic acid hematoxylin to show asteroid bodies, PAS and Brocott methamine stain for fungi, Zidane stain for MTD, Fight for Echo, which is again modified Zidane stain, can be used to demonstrate M. leprae, Gram stain for different bacteria, actinomycosis, nocardiosis, Gemsef for leishmania, Watkins stain for spirochete. Take home messages: the histological diagnosis of granuloma can be done in following stepwise order. In step 1, we'll identify the granuloma, whether it contains epithelioid cells or macrophages or giant cells by presence of these three. Step 2, identifying type of granuloma, whether it's sarcoidal, necrobiotic, foreign body, or tuberculoid. And then identifying the cause of granuloma by the presence of microorganism or foreign body. Histopathologically, when combined with special type, can serve as gold standard for diagnosis, categorization, and clinicopathological correlation. Thank you.